2 months, and ultrasound was done, which showed a prostate of around 90 grams. And the patient gave an history of taking aspirin, clopidogrel, metoprolol, and rosuvastatin since 3 years, and he is posted for TURP, TURP.
Okay. Yes,
So as the presenting
in this case, you anticipate. In the case scenario, how
Yes,
do
sir.
you first of all anticipate the problems? This is not a live patient, so you cannot ask any history or anything, but you have to formulate the questions to find out what are all the information that you want for this case scenario. Correct?
Yes, sir. Yes, sir.
Okay. So what other further information you want on this?
Sir, I would be wanting the history of the patient, sir, a proper history. Since the
Okay.
patient BP is highly uncontrolled, it's 180 systolic, 112 of diastolic,
Very
and
good.
patient is on multiple drugs, sir, aspirin, clopidogrel. So probably I would be wanting to know the history of IHD or other cardiac illness presentations, sir. So is it a recent MI or past MI, whatever it is?
Very good.
And the patient is in Foley's in situ, sir. So I would be wanting to know the date and the time of catheterization. When was he catheterized? What is the reason for catheterization? Obstructive uropathy. If the and again the size of the prostate gland is 90 grams, and if generally speaking, TURP can be an elective surgery. So I would want to stop the clopidogrel for at least 5 days, sir. So if it has been an obstructive uropathy, then I'll have to take up the case under emergency scenarios. So this would be my concern, sir. So if it has been more than 3 years, and if it's not because of obstructive uropathy, then I'll ask the surgeon to wait for at least 5 days to stop clopidogrel, stabilize the BP, do all the basic investigations. I'll want to know the cardiac status. I'll want to know about the smoking history, alcohol history. Since an elderly patient, I will have to know about the pulmonary reserve. So I'll have to do an PFT, chest X-ray, smoking history. I'll collect everything. I'll stabilize the patient, optimize the patient, then take up the surgery to prevent all other complications, sir. Then the morbidity and mortality will be very less.
Why do you think the patient is still on the Foley's catheter?
Sir,
This scenario.
So probably he might had an issue of acute retention of urine. Probably the glandular secretion has been completely obstructed the lumen. So he might have presented to the hospital for admission with an obstructive uropathy. So only with catheterization he would have been able to pass the urine out.
Very good.
So that might be one major reason.
Being able to pass the catheter, what they would have done?
They would have tried some rigid scopy techniques, sir, in which they will try to dilate or maybe under. Then SPC would have been an option, sir.
SPC.
So if
Supervised catheterization.
If the patient has not been able to pass with the Foley's catheter, automatically is to go for an SPC and acute retention. Okay?
Yes, sir.
And, they would have done a trial removal of the catheter and again you have gone in for retention. That is why they have advised to have a situ. What are the risks of having a catheter for such a long time?
Sir, the latest silica types of catheters can be kept for at least 2 to 3 weeks, sir. The traditional Foley's one might get crystallized on the ends and it might get obstructed. Again, by the leakage of the fluid, it might get obstructed. Again, removing the Foley's itself would have been a huge issue. They'll have to do it in ultrasound, deflating the bulb and all those things itself will become an issue, sir. This itself will cause bleeding and stricture of the urethra can be highly possible.
But what if now he is passing urine freely with the catheter in situ? So what is the risk in having a catheter?
Chances of urinary tract infection.
Infection. Yes, sir.
Yeah.
More chance of UTI.
Yeah, recurrent UTI. So how will you find out whether he had recurrent UTI or not with the Foley in situ? What questions you will ask the patient?
I will ask for fever.
Fever. Just anybody can get. But what is the classical presentation of urinary sepsis?
Sir, LUT is a lower urinary tract symptoms, sir. The burning maturation, difficulty in passing urine, the urge to pass urine.
So you won't have burning maturation.
No, in the past, in the history taking, I would ask all these questions, sir.
The catheter is there if the patient develops a recurrent UTI. What are all the features?
Fever with chills. Fever with chills.
Rigors.
Why do they get rigor?
Sorry.
Why do they get rigor? Am I audible now? Somebody mentioned that my voice is not heard.
Toxemia of the blood bacterium.
Septicemia, sir.
Hello?
Sir, you're audible, sir.
Hello?
Hello, sir. Am I audible, sir? Can you hear me, sir?
Hello?
Sir, can you hear me, sir?
Hello?
Yes, sir.
Hello?
Yes, Kamashi.
Sir's mic and the thing is having some.
Watching? Yeah. So rigor, fever with rigor, headache, nausea, vomiting, all these
Yeah.
things are very common for patient getting a recurrent UTI. Okay,
Yes, sir.
right. So what is the risk in operating a patient who has urinary infection?
Chances of
Postoperative
hemorrhage would be more,
bleeding.
sir.
Uh,
Intraoperative hemorrhage would be more for the patients who have recurrent UTI, sir.
Okay.
Bacteremia, sepsis also, sir.
That is more
Bacterial
important.
sepsis.
Urosepsis is very, very dangerous. It can kill the patient. Okay. So intra-op and post-op, how does urosepsis happen? Bacteremia happen. They have ongoing
The-
urosepsis. How can
Yes, sir.
bacteremia happen? By doing TURP in a patient who is harboring a urinary tract infection.
As more and
Ascending
more
infection.
prostate are resected,
Prostatic veins
the
are
infection
open.
from the
Okay?
yes, sir. Through it,
Prostate
it can
venous
ascend.
sinuses are open.
Yes,
Yes,
they can
sir.
get absorbed just like the fluid getting absorbed, the bacteria also can get absorbed. Okay.
Yes, sir.
So how will you decide whether it is fit for surgery or not? If it is
Do a
I'll look for the total
So-
count of the patient.
Total count of the patient.
really total count,
we'll do a urine culture sensitivity, starting on an adequate dose of antibiotics, complete it to
Yes.
whole course, repeat the total count, check his afebrile phase, then start take him for surgery, sir.
do you want to get a sterile urine? The culture should be negative. That is the first answer. Before
Yes, sir. Culture should be negative. Yes, sir.
You are worried about the total count all the time. But you must be more worried about the sterile urine. Okay? That is the indication that the infection has been cleared from the urinary tract. Okay?
Yes, sir.
Right. Now, what is the importance of mentioning that the gland size is 90 grams? Does it have any relevance?
It should
Sir,
be
because it
operated
usually-
only when the size is less than 60 grams.
60 grams.
So what to do? Leave him alone with the catheter all the time?
No, sir. Start on drugs which reduce the size of the prostate, such as
So-
alpha-1 blockers,
He is already on some drug for that. What is
He's
the drug?
already on tamsulosin for 2 months.
tamsulosin.
So that doesn't seem to be having any effect. So what do we do in that situation?
Probably can we ask the surgeon to do the surgery in 2 sittings, sir? Resect a part of his gland now and later again.
Excellent, excellent. That is called, what do you call that procedure? If you do it in the 1 or 2 sittings, is there any name for that? It's called
Okay.
staged surgery. Okay?
Ah,
You
it's a
don't
staged
do the whole
surgeries.
thing in one sitting. You do it in 2 or even 3 sittings can be taken. Okay?
Yes, sir.
Otherwise, if the patient insists, I don't want to come again and again to the hospital, you do it in one sitting. What will you do? The
Open
next one.
prostatectomy.
Open
Excellent,
prostatectomy.
excellent, excellent. Open prostatectomy, we may clear it and to approve it out the whole thing. Why people don't do open prostatectomy nowadays?
Sir, the chances of bleeding are more as well as
It is
post-operative mortality and morbidity is high, sir.
Very good, excellent. Okay. It's a blind procedure. They don't see anything. They just feel the gland and enucleate it. Okay, it is called enucleation of the prostate. But the method of surgery in the olden days, which is now practiced by many of the young urologists, might not have even seen that procedure. Okay, so that is these are all the options. Right now, with this patient, what are the pre-op investigations you want to do in this patient? With all
Routine,
the necessary
So routine all investigations starting
Routine
with
complete blood
CBC,
count.
platelet.
One of you at a time. One of you at a time.
So routine investigation starting with complete blood count, platelet, liver function test, renal function test, coagulation profile, ECG, baseline ECG, on chest X-ray.
Echo also, sir.
2D echo
2D
as the
2D
patient is in the
echocardiography, sir.
geriatric.
So all these things about to find out what you want to find out by doing all these investigations.
So first here CBC, I will try to estimate the hemoglobin level, sir.
Okay.
So first thing to do is to calculate the allowable blood loss during the surgery. But only by knowing the hemoglobin, I'll be able to calculate this. And again, what would be the expected hemoglobin later? Then platelets, again, to take up him for an elective surgery, I would need an minimum platelets of 1 lakh, sir. So that would be necessary. And in giving more importance to the history of the drugs with clopidogrel, I would be asking an PTINR and if possible TEG too, sir.
Okay. So with the hemoglobin value preoperatively, can you find out the amount of blood loss that is happening after the surgery?
We can estimate the allowable blood loss, sir.
Allowable.
With the
Allowable.
formula
I'm
of
not asking about allowable. After surgery, how will you find out how much of blood has been lost? Utilizing the preoperative hemoglobin and limited blood value.
we can do an estimation of the irrigation fluid hemoglobin, sir,
Irrigating fluid hemoglobin.
divided by the patient's hemoglobin and the volume of irrigation fluid. By this, we can estimate the fluid which has got absorbed. So for this too, hemoglobin would be necessary.
No, I'm asking about that loss. How much of blood the patient has lost?
Sir, post-operatively, I'll recheck the hemoglobin, or intraoperatively, I'll send a serial of hemoglobin levels, sir, to keep assessing the hemoglobin levels.
Very good.
So to know how much of blood is lost.
But on the table immediately after surgery, you cannot find out. You already set a formula utilizing the hemoglobin.
Irrigating fluid hemoglobin
Globin
By the patient's hemoglobin into the volume of irrigated
amount
fluid.
of
Hemoglobin and the patient's irrigating fluid multiplied by the volume of irrigation fluid divided by the perioperative hemoglobin, you will get the blood loss actually. Okay?
Yes,
So
sir.
that is the method of doing it. The table. Similarly, there is a formula for calculating how much of fluid has been absorbed. Do you know that formula?
10 to 30 ml per minute of resection.
15 ml per every gram resected.
That is a rough idea, but exactly.
Perioperative NA by postoperative NA into
preoperative.
ECF minus ECF.
Yes.
Yes.
Sir.
So you should not only do the CBC, but also you must measure the sodium, in all
Sodium
the
levels.
patients who are
Yes.
coming for therapy. Okay? It's a very, very important area of investigation and documented so that in case of problem occurring, like the TURP syndrome, then it will be useful to find out whether the patient was hyponatremic even prior to surgery, because elderly people are likely to have hyponatremia, a milder form that may get aggravated. So we do not know whether he had a normal sodium preoperatively or whether it got diluted after the surgery. It's also very important. So always must insist on doing a preoperative sodium estimation in these patients. Okay. So these investigations give you an idea. Will you ask about the patient's effort tolerance?
Metabolic equivalence. We'll ask
Yeah,
for the
metabolic-
metabolic equivalence of the
That
patient.
is a very important point, especially after 3 years of cardiac medications. You must find out whether he is stable or whether he is deteriorated, what is his day-to-day activity.
It's
Any other important questions you should ask apart from this cardiac evaluation? Because of his age, he's 70 plus. So elderly age group, what are the other associated problems which can
COPD,
trigger
sir.
the surgery?
Complications of
COPD.
hypertension,
Okay.
the end organ damage of
end organ
hypertension.
damage of hypertension,
Hypertension.
Okay.
retinopathy, nephropathy, and
So I'll go initially with the heart, sir. So atherosclerosis, angina, stable
LDH.
angina, unstable angina.
Okay. Right.
Then I'll go with brain, sir. I'll ask a history of CVA.
Very good.
Then I'll go with kidney. Then I'd like to ask about the nephropathy, sir. So any serial ultrasound evaluation was done? Was there any
And peripheral
heterogeneity found?
vascular diseases also,
All
sir.
that is all with regard to hypertension and its complication. One
Sir, with respiratory system, I'll have to know about
Respiratory
COPD, sir.
COPD. Okay, here there is no, say, case scenario does not say that he has any COPD.
No.
What other age-related complication you would anticipate? What about the joints, musculoskeletal?
Yes, sir,
Osteoarthritis
yes,
is
sir.
the
There will be
most problem in
degeneration,
positioning of the patient.
positioning of the patient.
Not only in position, what else it can give trouble to you? Causing all the spines are all fused.
Yes, sir.
and-
Degenerative changes in the vertebral column would make the spinal anesthesia itself very difficult, sir.
Okay. So the patient's positioning before that, the anesthesia itself can be
Can be difficult.
because of the calcification of the supraspinal and spinal ligaments. Everything may be quite hard and tough. Your needle sometimes may get bent also if you use a very fine needle. Okay.
Yes, sir.
They start from there. So you must ask about this mobility in any previous surgery, especially the hip. We have had a hip replacement. I think the leg may be a problematic thing.
Yes,
And
sir.
what other neurological conditions can be associated after the elderly?
Delirium.
Delirium,
You call it a delirium or
Cognitive dysfunction.
reduced
Cognitive
cognitive
dysfunction.
cognitive
Reduced
dysfunction?
cognitive.
Then cognitive dysfunction may be there. Then
Dementia.
dementia, very good.
Dementia.
Then nowadays, very commonly you see every second patient in 100 you see this problem. Parkinson's, okay?
Yes, sir.
Neurological problem, Parkinson's, Alzheimer's disease, all these things are because of the longevity, the long life. So Parkinson's is another problem. Okay? What are the difficulties in operating for a patient for TURP with Parkinson's? Manifestation of Parkinsonism.
Involuntary tremors, sir.
Tremor,
So,
okay. Another
Tremors.
manifestation. Rigidity.
Rigidity. Yes, sir.
Difficulty in
Rigidity.
positioning.
Leg
Positioning.
pipe rigidity. Isn't it?
Mm.
So if the patient is having predominantly a rigidity problem, even after spinal, the legs may not become relaxed.
Yes, sir.
As you have done cases, you won't know. So it will be very difficult. Even with a good acting spinal, the muscle may still be stiff and it will be very difficult to question the patient. Okay? So all these associated age-related problems have to be ruled out. Right. Now we have evaluated this patient and you have even in fitness. Now what are all the, how are you going to manage this patient? What is the anesthesia of choice?
Final
Spinal, sir.
anesthesia, sir.
Spinal anesthesia is the preferred technique for this. In spite of all the cardiac problems, would you still go for spinal anesthesia?
I look for the ejection fraction of the patient, sir. If it is less than 35,
35,
I'll go for
I'll go for
general
GA.
anesthesia.
Central anesthesia. So why do you want to avoid spinal in a patient with a low ejection fraction?
So they won't be able to tolerate the minimal hypotension, which should be definitely a causative agent of spinal anesthesia.
Okay. What is the level of block you require for this surgery?
T10, sir.
T10, sir.
Why do you
T10.
want it to T10? What is the nerve supply to
The
state?
So nerve supplies
Bladder.
T12 to L2, but the bladder distension discomfort can be masked with block up to T10.
Okay, right. So supposing you ask the surgeon to not to inflate the bladder too much and remove the irrigating fluid on and off without stretching the bladder too much, can it be performed with a low block of cyclic fixes alone?
Can be, sir. Study has shown that even with the epidural, it can be done by blocking the sacral plexus.
That is another possibility there, isn't it?
Yes, sir.
Yes,
You
sir.
can even do it under caudal block.
Caudal block, but finding
Yes,
the
sir.
caudal will be more difficult in an elderly, sir.
Difficult in old age.
Okay, technically difficult. What other problem will be there if you plan for a caudal?
inadequate block.
See, the prostate is supplied only by the sacral and pudendal nerves.
Yes, sir. S2, S4.
So if you are able to block that, you are not going to cause much of a pain to the patient. The bladder distension only is going to cause, you require a block up to T10.
Peter.
But with a caudal block with an adequate analgesia for the prostate area, what other difficulty you will have?
Operator nerve.
It is only for bladder tumor resection, where the operator nerve will stimulate and the legs will they get blocked?
Positioning.
No, sir. The position it will be painful.
Yes. So the leg will not be relaxed. So positioning will be a problem with caudal. Okay. So unless the surgeon is very much experienced and we can do it in a supine patient without stretching the legs, then it can be done under caudal. And the patient even 25-30 ejection fraction, we have done like that without positioning the patient. The lithotomy, if we can manage, we can do that also. Just make a section enough to create a channel, not complete resection of the gland. Okay. So these are all the things that you have to think about. So after spinal, how will you know that whether the patient is going in for any Turp syndrome or not?
The first presenting complaint would be restlessness, sir.
Restlessness,
Agitation,
confusion.
confusion, sweating.
Excellent.
So this
Sweating,
because
why should sweating occur? I don't think sweating is not a problem. I not treat sweating as a component of Turp syndrome. Agitation, restlessness, then what will happen to the cardiovascular response?
The
initial
hypertension,
hypertension, then hypotension, sir.
hypotension.
What will happen to the pulse rate initially before the blood pressure?
Bradycardia.
There'll be reflex brady,
Bradycardia.
then tachy. Reflex brady, then tachy.
First thing is brady. So in a patient who has been having a normal pulse rate of say 75, 80, 85, suddenly goes in for a brady of 50, 45 like that, and then you find the blood pressure which was hovering around 110, 80 goes up to 140 by 100. That is the earliest sign of Turp syndrome because the fluid has been absorbed and the volume low is happening. So if you miss the bus at that stage, what can happen? You fail to take note of that brady and hypertension. What can happen?
Pulmonary
Will
edema.
lead to
Pulmonary
hypotension and bradycardia.
Say patient will be restless. After that, what will happen? You will become
Seizure and
disoriented.
Seizures and coma.
Seizure.
Yes, sir.
You will become disoriented. Restlessness
Yes, sir.
is something. What is the difference between restlessness and disorientation? What will be the clinical presentation of restlessness and what will be the clinical presentation of disorientation?
Restlessness patient will be able to convey what discomfort he is feeling, sir.
He will start fidgeting. He will pull out the IV line. He will try to take
Yes, sir.
out the oxygen mask. But if you ask him what is his name, he will still be able to answer that.
Answer it.
But
Yes,
when
sir.
he becomes disoriented, you ask him a relevant question, what is your name, what is your age, he won't be able to say that. He will
Yes,
be
sir.
still fidgeting also. Okay? Restlessness is there where he is able to comprehend your questions. Disorientation is that where he is not able to respond to your questions, but he is still having some irritability. Okay?
Yes, sir.
Then finally it may end up in a seizure or he may become comatose completely. Okay. Now
Yes,
if supposing you identify this condition as Turp syndrome, what is the first thing you do?
So 100% oxygenation. Will advise the surgeon to achieve
Tell
hemostasis
surgeon to
and
stop the
close up
surgery.
at the earliest.
Stop the surgery. That is the first and foremost thing. You must
Yes, sir.
communicate it to the surgeon and tell him that you have to stop the surgery for some time
To act-
and then give 100% oxygen. Then what is the next step?
Sir, send an ABG sample immediately to assess the hemoglobin level, osmolality, and the sodium levels. So if
What's the sodium? More than
sodium, yes, sir.
osmolality and all that, you must have a sodium estimation done.
Yes,
Okay?
sir.
That is very important. Documentation also is very important to prove that your diagnosis of Turp syndrome is correct. Okay? So, what are the various levels of sodium at which the presentations in the CNS, CVS, and the ECG?
Usually,
So 120.
hyponatremia starts off with 120, in which whereby CNS there would be confusion and restlessness. CVS would be presented with hypotension and bradycardia. ECG there would be changes of wide QRS complex, sir. And when it attains a level of 115, patient would complain of somnolence, nausea and vomiting. And CVS would be cardiac depression, bradycardia again. And ECG changes would be wide QRS with elevated ST segment. Whereas when it attains a level of 110, patient would be presenting with seizures, ultimately worst case scenario into coma. CNS would be congestive cardiac failure, and ECG would be ventricular tachycardia or fibrillation, sir. So all those arrhythmias.
Very good. Excellent. So all these things can happen. So what is the further management after giving 100% oxygen? The patient is still comatose or throwing a fit. What is your management?
GA, sir.
GA.
Yes, sir.
Already BP is low. You said patient may have hypertension, bradycardia. Is it advisable to go for GA at this time?
So if he's still okay, if he's still throwing a seizure, we'll try to control the seizures probably with magnesium
What are all
sulfate.
the, why magnesium sulfate? Why do you want to give magnesium sulfate in terpenoid or compost or benzodiazepines?
The magnesium sulfate will stop the influx of the calcium, sir. Again, it will stop the release of the GABA. So it will act on the presynaptic membranes. So the conduction of the action potential itself will be blocked. So the seizure activity will be much lesser rather than going for other AEDs where just the threshold of the seizure activity will increase in the brain. This will act in the presynaptic membrane. And MGSO4 again is more neuroprotective and much helpful, sir.
So is it the reason for that, or it will magnesium also will become low?
Yes, sir. Probably by dilution hypernatremia magnesium levels also would be low.
Yeah, that is the more important thing. Because of the dilution, magnesium itself will become low.
Yes, sir.
And if supposing he has used glycine as an irrigating fluid,
Yes, sir.
it will compound it more. Okay. So
Yes,
in
sir.
that situation, magnesium sulfate is very much indicated. Okay. Not the
Yes, sir.
conventional phenytoin or benzodiazepine. Magnesium sulfate
Yes, sir.
is the right choice because of these two reasons. Okay. Right. So you give magnesium sulfate. What about the airway? You have to take care of the airway, isn't it? Patient may be comatose, not responsive. If GCS is less than 8.
Yes, sir. Then I would try to achieve a definite airway, sir.
How do you do
Intubate
that?
the patient.
I'll try to intubate the patient.
With what? Can you
So,
just leave it intubate if he is throwing a fit or is clenching his teeth? Can you intubate the patient?
yes, sir.
oral airway.
I'll induce.
The airway is only a protection against upper airway collapse. But if you want a definitive airway, what is the method? What relaxant do you want to use?
Sir, we'll
Direct
try
way of
to
asking the
induce.
question.
Yes, sir. I'll try to induce the patient with thiopentone.
Already he is comatose. Why do you want to give thiopentone again?
And muscle relaxant, succinylcholine.
Straight away go for a muscle relaxant. Why do you want to give thiopentone?
Yes,
here?
sir. Then succinylcholine, sir.
You can, sir, it's an emergency situation. So you have to go for succinylcholine and intubate the patient and
Sir.
secure the airway and ventilate the patient. Okay?
Yes, sir.
So these are all the sequence you have to follow. First of all, stop the surgery, % oxygen, reduce the fluid. What is the method of removing the fluid that has been absorbed? That is the third step.
Yes, sir. We can use diuretic, sir. Furosemide
What is the
or
dose of diuretic?
mannitol.
What diuretic you will use?
Injection prosamide.
Furosemide, sir. Furosemide.
Mannitol should not be used. Why? It's in mannitol. Already volume
sir.
overload is there. If you mannitol, what will happen? Will it not absorb fluid from the interstitial and intercellular spaces and then increase the volume and then only cause diuresis? It's an osmotic
Okay.
diuretic.
Osmotic
Yes, sir. Yes, sir.
So there's no
Okay,
role for mannitol in this. You have to go only for furosemide, loop diuretic.
Yes,
What
sir.
is the dose of loop diuretic you will give?
20 mg stat,
20
sir.
mg
If the
IV
patient is already had been a diuretics, then I'd go for 40 mg stat.
40 mg. You have to go for a higher dose. Okay, so
Yes, sir.
that way you must know the drug history of the patient. If he's already taking diuretics chronically for any cardiac condition, you have to go for a higher dose in the initial phase itself. So first instruction is to stop the surgery. Second is to go for 100% oxygen. Third is to give diuretic. And then before giving diuretic, take a blood sample, send it to lab for investigation, and then proceed with further resuscitation of the airway, control of seizures, ventilation and all these things. And then once the fluid has been removed, there will be cerebral edema also, isn't it? Because of the fluid of the overload.
Yes, sir.
Pulmonary edema can happen. How to manage those two things?
Pulmonary edema, I will intubate the patient. If the patient is already on.
Now you have
Intubation.
intubated. What else will you do to control the pulmonary edema?
Steroids and
Steroids
nearly, sir.
will it-
Morphine, sir.
What about ventilatory strategy?
PEEP, sir.
I'll
100%
PEEP of
auto
8
with
to
PEEP.
10 centimeter. of
100% auto with PEEP.
Yeah.
water.
Positive ventilatory expiratory pressure. Okay, that is the important ventilatory strategy you have to follow. And for cerebral edema, you can give steroids. Again,
Yes, sir.
here giving mannitol for that is not correct. You have to go only for steroids too. How does steroid help in controlling the cerebral edema? All of us say that we have to give steroids if there is cerebral edema and then but how does it help? How does fluid go out of the vascular compartment into the
Sir, it will lower the intracranial pressure, sir. Primarily, which is of the vasogenic edema will be reduced.
The blood-brain barrier. That is the answer.
Okay, sir.
This steroid will strengthen them or stabilize the blood-brain barrier so that fluid does not go from the vascular compartment into the interstitial space. And that is the mechanism by which steroids help. Okay. So this is one of the important complications. Supposing he has been using a lot of glycine as an irrigating fluid.
Yes, sir.
Complications that can happen because of glycine.
So most commonest is
Hyperammonemia.
hyperammonemia, then transient blindness, sir.
Blindness.
What is the mechanism?
Sir, this visual
The
disturbance
glycine is
occurs because of
metabolized to
glycine.
ammonia and glyoxylic acid.
Glycolic acid.
That is
You're asking about visual disturbance, sir?
the general toxicity of the glycine.
So glycine itself is an inhibitory neurotransmitter.
Neurotransmitter, very good.
It stimulates the NMDA receptors in the
NMDA
brain
receptors.
and provokes seizures.
Seizure.
Right. It could cause transient myocardial depression can happen. Glycine is a myocardial depressant also.
Yes, sir.
Also will happen with glycine and visual transient visual. What is the normal level of glycine? Do we have
13
glycine
to
around
17
17 millimoles
milligram per liter.
What is the half-life of glycine?
85 minutes, sir.
85 minutes.
85 minutes. That's a long time. So, what are the other complications operating? Can happen.
Hypothermia, sir.
Hypothermia. What is the
Bladder
cause of
perforation.
hypothermia?
Because of the
Cold
cold
irrigation
irrigating
fluids.
fluid.
Getting fluid is cold, you can get hypothermia. Patient will be exposed to ambient temperature and age it causes for elderly patients.
Diminished thermoregulatory mechanism.
Thermoregulator mechanisms.
They become more hypothermic. So the hypothermia is another problem. Then what about the bladder perforation you mentioned? How do you identify bladder perforation?
Patient will complain of shoulder pain and
Shoulder
COPD
pain.
Okay. Then the surgical field, what is the response you see?
The irrigation fluid amount would be reduced, sir.
A non-return of irrigation.
There would be extravasation of the fluid happening. So the
Non-
input of the fluid and the output would be reduced. That would be the first sign, sir.
Excellent, very good. What will happen to the abdomen if you observe that? The surgeon has perforated, but he is not taking note of it. He is a new surgeon, otherwise, and he doesn't observe that the return is not that much as he is putting in. He continues to do the resection. What will you see in the lower abdomen?
Distension of the abdomen, sir.
And you will find a bulge because the vessel
Yes, sir.
bladder has been perforated and extravasation will happen. So you will find a suprapubic bulge happening. Especially in a very thin patient, it will be very nicely seen.
Evident.
Evident as though it's a obstructed bladder with a retention. Okay? So that will be easily seen. Patient will also complain of pain shoulder. Why pain in the shoulder?
Due to diaphragm irritation, sir.
Irritation of the diaphragm. Very good. So this is another thing. What we have to do is, supposing surgeon recognizes that he has punctured the bladder, what should we do?
Note it to the laparotomy and proceed, sir.
Depends on the size of the hole. Okay, so you can visualize that hole. To be small, it can get corrected by itself. But if it is large enough and extra incision has taken place, he has to open and close the rent. Otherwise, it will start moving. But post-operative also, they may be using irrigation. Okay? So that
Yes.
is the complication that we have to take care of. So, supposing the bleeding continues intraoperatively and post-operatively, hemorrhage is one of the major complications of PRP surgery, isn't it?
Yes, sir.
Yes, sir.
We can treat with tranexamic acid, sir, 15 to 25 mg per kg.
Okay.
Or we can give epsilon aminocapryonic acid, sir, during the first
What
start.
is the reason you want to give
So tranexamic acid is a competitive inhibitor. It will plasmid, sir.
So,
So,
it's a fibrinolytic drug.
fibrinolytic drug. So the
Yeah,
best time to start off is before the hemorrhage occurs.
It's an antifibrinolytic drug, so we are giving it for all three types of surgery. Isn't it?
Yes, sir.
Tranexamic
Yes, sir.
acid is very commonly used in orthopedic surgeries nowadays. Okay, so that is
Yes,
the
sir.
general drug.
Is it, sir, why is it more common in prostatic surgery?
That's a answer.
Because of the release of urokinase from the
Prostatic
prostate
cancer.
gland, sir. As more and more is resected, the urokinase will convert plasminogen to plasmin, which will lead to more fibrinolysis.
It is like a blockbuster. What you give urokinase is the drug you use for myocardial infarction treatment also, isn't it?
Yes, sir.
Thrombolytic agent. So
Yes,
it
sir.
will not thrombolysis, so it will not allow the thrombus to form and bleeding will continue. So for that, the ideal antidote is epsilon aminocaprylic acid. More than
4 to 5 grams first, followed by 1 gram per hour.
can DAC happen in these patients?
Yes, sir.
Definitely, sir.
Definitely.
Yes, sir.
How do you
Yes, sir.
differentiate between hemorrhage due to urokinase release and DAC?
So DAC triggered by prostate would be because of systemic absorption of the resected prostate tissue, sir, which will be rich in thromboplastin.
Very good.
Whereas other would be because of depleted platelets, sir.
How to find out, diagnose? I'm not asking the pathophysiology. I'm asking how to diagnose it. How to make a diagnosis whether it is DAC. What the point of care testing we have nowadays to identify that.
Increased fibrin degradation products.
D-dimer helps, sir.
It means you have to do it under the bedside. Fibrin degradation product, you have to send it to the lab and find out the D-dimer. When you say testing, it should be available at the bedside of the patient.
Bleeding time, clotting time can be, or TEG can be done if it is available.
Thromboelastography. Nowadays, everything can bedside testing. So, thromboelastography will give you a clear picture whether it is DAC or whether it is platelet deficiency or whatever it is, it can be found out. So, what will be the picture of the thromboelastograph in case of DAC? All of you have seen pictures of something like a cherut. Classical graph of
The alpha angle will be prolonged and the curve will be elongated.
Initially, the clotting will be very sharp and very brisk because DAC, you know, it's a consumption coagulopathy. It utilizes all the clotting factors and initially it forms thrombus. That is why it is called disseminated intravascular coagulation. After the coagulation, it's the coagulation pattern. So the initial faster rapid coagulation, then followed by a prolonged fibrinolysis with a lot of prolonged elongation of the graph. So double picture, combination of rapid coagulation followed by delayed clotting. So how to treat that? With the DAC, how do you treat that? So it's a very tricky situation. You have to prevent thrombus formation at the same time. You must allow coagulation also to happen. So how to treat that?
Depending on the if TEG is available, depending on the alpha K values, you can supplement what is needed for coagulation. Platelet, fresh frozen plasma, or cryoprecipitate can be given depending on the.
So normally, will be the ultimate step of clot formation is conversion of fibrinogen into fibrine. Okay. So fibrinogen will be completely will be so the thing is to same small. It's a combination of these two, and once when the bleeding comes under control, you go for fresh frozen plasma and platelets, not even initial stages. Okay, so first replacement is always the fibrinogen, followed by 500 units of heparin, followed by fresh frozen plasma and platelet. That is the treatment for replacement. Okay, right. So these are all the complications that happen. However, the post-op problems you can anticipate in this case, especially this patient being on cardiac medications for the last 3 years. What are the what particular care you will exhibit in this patient? What are the things you have to avoid for him to have prevent the recurrence of cardiac issue? Like
Post-operative pain relief, sir.
pain relief, very good. How do you achieve that? Can you plan for post-operative pain during administration of spinal anesthesia?
Sir, additive in
Yeah,
spinal and
epidural. I can supplement with epidural.
Supposing you do a single shot spinal, can you do something in that?
so additive we can add either
Fentanyl or
fentanyl or
morphine.
buprenorphine.
Morphine or
Morphine.
Morphine, all these things. So preservative free morphine or buprenorphine can be added to prolong the duration of pain relief. One, right? Okay. Then any other method? What is the cause for the post-operative pain? Is it arising from the bladder or is it due to some other reason?
bladder.
Continuous irrigation of the bladder.
Continuous irrigation is going and coming out, staying in the bladder. Bladder is not getting disturbed.
Stricture urethra.
What is the purpose of this irrigation? Why do the surgeons start doing irrigation?
To remove whatever debris are inside and to prevent the
Clot
clot, sir.
Prevent clot. Debris, most of them you remove, but the clots we should not allow it to form. That will block the catheter and prevent the drainage. So wash out whatever bleeding is happening. But how do they stop the bleeding post-operatively? Because the sinuses are all open as much as possible. They try to coagulate it during surgery, but venous sinuses cannot be completely closed off. All of them. So there will be some amount of losing is expected. So how do they stop that? What do they do after the surgery? What type of catheter they pass into the
Three-way.
bladder?
Three lumen catheter.
Three
Three lumen
way
catheter.
catheter. Okay. Very good. So what do they do with the catheter to the main thing to arrest the bleeding, post-operative bleeding? So how
Bulb
do they
will
do
be
that?
inflated and kept inside.
How much volume is put in the bulb?
Twice.
Normally, when you pass a catheter, all of you, as an oxygen pass catheters, that must have been the duty given to you, isn't it?
And depending
Yes,
on the size of the catheter.
Normally, for an adult, they put about 40 ml.
But
Okay, normally, we put only about 10 to
10 to
15 ml,
Yes,
and then 20 ml.
10.
To apply the bulb with the 40 ml of saline, then do they just allow it to float inside the bladder?
No, so they will pull it,
Yeah.
put a traction, sir, so that it doesn't move. They will put a traction on the inner thigh.
Yes, that is the most important thing. The traction only is going to cause tamponade, pressure on the prosthetic bed,
Yes, sir.
and compress all the venous channels to prevent the from bleeding. Okay, but by helping this stop the bleeding, what does this balloon, inflated balloon, can do? Where is it going to press? Which area, which part, anatomical part of the bladder is going to press?
Apex.
Apex.
Neck of bladder.
Apex.
Apex. Neck of bladder.
Between the two ureteric opening, what is the area called? There are three openings, two ureters and the urethra. Between these three openings, what is the area of the bladder called? Trigone.
Trigone.
So
Yes,
it's a
sir.
triangle. Okay. So two ureters open on two sides and the urethra opens downward. That area is very, very sensitive area. The trigone area of the bladder is the area. So this balloon that you inflate, the Foley balloon that is inflated with 40 ml of saline, so it compresses the venous sinuses and prevent the bleeding. It is pressing on the trigonal area also, which is rich in sensory supply. So once the patient anesthetic effect wears off, this trigonal irritation will be the main thing which will cause it, make him restless. Okay. So how can you prevent that? It will produce. Supposing the trigone is irritated, what will the bladder do? The pulsar muscles, so the bladder. They will go into contraction. Okay? That is called bladder spasm. Okay, so that bladder spasm is the most painful thing. So that has to be abolished. Okay, so people give drugs which can prevent the contraction of the bladder. What drugs can be given? With contraction is due to which part of the nervous system? Sympathetic, somatic.
Parasympathetic.
Receptors. Okay. Now,
Yes, sir.
for overreactive bladder, urologists prescribe antimuscarinic agents.
Hyoscine.
Hyoscine bromide.
Hyoscine butyl bromide.
Bromide or other drugs are all available. So such drugs are given to reduce the spasm. Okay. So by any amount of giving opioids or other things will not be that. Otherwise, you have to release the traction. If it is too tight and if it is being stretched too much, you have to release the traction, the patient will become fine. So pain management is very important, especially with a patient who has had a previous cardiac issue. Then what is the next thing that you have to take care of to prevent a recurrence of myocardial problem? Apart from pain.
He should not strain on stools, sir. He should not strain on
So
stools.
we should restart the antiplatelet medications which we had stopped.
For the immediate post-op. Shivering.
Shivering, hypothermia.
Shivering should be prevented. Okay. So you have to. That's why immediate pre-op you have to make sure that there is no residual urinary infection, and intraoperatively you have to maintain normal apnea. And post-operatively, sometimes patients start shivering. So at the time also you must make sure that he is not exposed to very low ambient temperatures and covering with warm blankets. How much oxygen demand can increase if the patient starts shivering? Why shivering is dangerous to produce a myocardial ischemia infarction? Because it increases the oxygen demand. So there is an imbalance between supply and demand. It can increase up to 200%. Okay? The shivering of the skeletal muscles can result in demand increase of oxygen by up to 200%. So you have to prevent the shivering, give supplemental oxygen, and make sure that the pain is alleviated and bladder spasm is prevented. If all these things, patient will be fine. So, supposing the bleeding continues post-operatively, and any amount of tranexamic acid or even other measures, and all the conservative managements fail, the surgeon, what can he do ultimately as the last resort to stop the bleeding? This is a surgical intervention that can be done.
Ligation.
Ligation, very good. Ligation of what? Internal iliac artery.
Internal iliac artery. Yes, sir.
That will lead
The
to
prostate
what
artery.
is the blood supply to the prostate gland. Why you have to ligate the internal iliac artery? Which means the branches of the prostate gland are received from the internal iliac. So what are all the
Yes.
branches of internal iliac which supply the prostate gland?
Sir, inferior vesical artery, middle rectal, and internal pudendal, sir.
Excellent. Excellent. These are the three, all of them from branches of the internal iliac. So you go to the main artery and ligate it, and you can dispense with the internal iliac artery. Which other condition you will do internal iliac artery ligation in a female?
PPH, postpartum hemorrhage.
Postpartum severe uncontrollable hemorrhage, you have to go to bilateral internal iliac artery ligation. Okay. Bilaterally, both the internal iliac arteries in a female. So for a male, the indication for internal iliac artery ligation is postoperative uncontrollable bleeding from the tube, prostatic bed. Okay. So these are the ways that you have to do. Finally, what is the physiology of micturition? How does micturition happen? Main problem in TURP is micturition, isn't it? The main complaint with which the patient comes to the doctor will be with this regard to micturition. So, what are all the micturition complaints we will have, and what is the physiology of micturition? In the various categories, what is the American Urological Society classification of micturition difficulties? The scoring system, American Urological Society micturition scoring system.
Based on the symptoms of the patient who's got a enlarged prostate. That's all.
Hesitancy. Hesitancy. Going to the restroom, he feels the urge to pass urine, but he goes to the restroom and he cannot immediately start urinating. So there's a time delay. This is hesitancy. Then intermittency. As he is passing, he suddenly stops. The third is the stream becomes thinner and thinner. Frequency. He goes, voids, come back within another 5 to 10 minutes or half an hour. He wants to void again. Frequency. Urgency. He feels like going before he could reach the toilet. He sometimes wets his pants. And nocturnal urination. Frequency in the night. And dribbling. Sometimes, even after finishing, there is some dribbling that is happening. So there are 7 different presentations of urination. Hesitancy, intermittency, stream becoming thinner, frequency, urgency, nocturnal emesis, urination, and dribbling. Okay. Based on this, they give the scoring. American Urological Society scoring is there. Now the next question, what is the physiology of micturition? How is micturition controlled? What are all the centers we have? What is the afferent? What is the efferent? Is it a volitional act or an involuntary act? Urination.
Circulational act, sir.
Volitional act up to some limit. Isn't it?
Yes, sir.
If your bladder
Yes,
is too full, you don't want to be in the front of everybody. Isn't it? You rush to the restroom as quickly as possible so that you don't wet your pants. Okay.
Yes, sir.
Yeah. So how is it? What are all the centers involved in the control of micturition?
Sir, afferents is through the sympathetic fibers in the hypogastric nerve and pelvic nerve, sir.
Very good.
Visceral afferent.
Very
It
good.
goes and acts in the Pons and Pontine center, sir.
So there are 3 centers. One in the higher centers there because we are all sophisticated animals, so we don't want to do anything like animals. We don't want to just like that pass urine in front of everybody. So there is a frontal control, so the head central control over the pontine center, and then there is a spinal center. So there was three
Yes, sir. Spinal.
centers.
Yes, sir.
So all
Lower
these things
thoracic
are-
and upper spinal cord, pontine center, and efferent is through the somatic nerves through the pudendal nerve, sir, which act on the external urethral sphincter, and hence the voiding of urine occurs.
Very good. So there are basic things you have to remember is sympathetic causes storage of urine by
Yes, sir.
relaxing the bladder and controlling contraction of the internal sphincter. Whereas parasympathetic contracts the detrusor mainly for voiding. The pudendal nerve for relaxation and control of the external sphincter.
External sphincter. Yes, sir.
These are all the three nerves which are involved. Sympathetic for storage, parasympathetic for evacuation, and pudendal for release through the sphincter. All the three nerves have to be activated, and they are inhibited and controlled depending upon your air control also. So when the bladder capacity exceeds 3 times its normal capacity, then only you get the urge to pass immediately. So you
Urine,
cannot
yes, sir.
control it anymore. At the time it becomes involuntary. If you don't go, you wet your pants. That is what will happen. Okay. So these are all the things that we have to know about the sleep management.
Sir, this is the same application that is there for urinary retention following spinal anesthesia, no, sir?
The retention is because you block the parasympathetic, no? Lower S2, S3, S4, pudendal are all blocked.
Because of that,
So,
yeah.
because of that uninhibited activity of sympathetic is there, which causes a relaxation of the bladder, and patient does not feel until it becomes more than T10 level, until the bladder distension is too full. Even then, they may not be able to void because of the blockage of the parasympathetic. Treatment of this thing, of course, we have finished the treatment for Turp syndrome also. Actually, can I go for
Yes, please, sir. Yes, please, sir.
That's a ASM rule of 60, sir.
Yeah, rule of 60.
Yes.
It should be operated in elderly above the age of 60 years. Should be operated
60
only up
centimeter
to
hydrostatic pressure.
60 grams of prostate only should be operated. The height of the irrigation should be at 60 max 60 centimeter above the symphysis pubis. The hydrostatic pressure should be 60 centimeter of water, and the duration of surgery should be less than 60 minutes.
Excellent.
Very good.
Yeah, that's all rough guide.